Hi, this is Dr. Bruce Lessey, and today my Pearlcast is on fertility in a woman with advanced maternal age. The focus of this Pearlcast will be to ask what are the factors that should be considered when treating infertility in women with advanced maternal age, and secondly, what affects endometrial receptivity for implantation in the older woman. There is a natural decline in female fertility with advanced age, both in natural cycles and in IVF. This is due primarily to the age of the oocyte, and it has more to do with the ovary than any other factor. The endometrium, on the other hand, is relatively immortal and does not appear to age in the same way that other tissues do in a woman's body. When we talk about endometrial receptivity, we ultimately talk about an implantation window. On the left, you can see a schematic showing the relationship between the ovarian development of the follicle and the endometrium. As the follicle develops, there is estrogen produced, making the endometrium grow. And after ovulation, with egg pickup and fertilization, the embryo is transported down the fallopian tube in a way that it arrives just in time so that the progesterone secreted from the corpus luteum has prepared the endometrium to a satisfactory state for implantation to occur. On the right, you can see that in a large prospective study by Wilcox, performed in 1999 and published in the New England Journal of Medicine, that the miscarriage rate for women that implant between LH plus 6 and LH plus 9 is only 13%. But when implantation occurs on days 10, 11, or after day 12, this miscarriage rate goes up significantly. These data would suggest that synchrony between the endometrium and the embryo and the corpus luteum are very important for success of pregnancy. Now, uterine receptivity has been shown using several different techniques. Here we can look at electron microscopy pictures in the upper right of pinapods, which reflect the normal receptive endometrium. In the lower left, we see an embryo attaching to those pinapods, and on the lower right, you see the pinapods outlined with a marker of receptivity known as osteopontin. Such biomarkers are useful to study endometrial receptivity. Endometrial receptivity requires a viable embryo, a hormonally competent ovary, and a corpus luteum. It also requires a lack of significant inflammation or inflammatory conditions, adequate endometrial preparation in terms of estrogen and sequential progesterone, and immune compliance. Now, the acquired defects that occur in a woman with age are listed here on the left. The first I'm discussing is luteal phase deficiency. This is a plausible explanation for the decrease in fertility that occurs with age, because during the perimenopause or women approaching menopause exhibit shortened luteal phase that might inadequately prepare the endometrium for implantation. This problem, luteal phase insufficiency, should be overcome with hormone support, such as HCG or progesterone. A second acquired defect that occurs as a woman ages includes the development of uterine fibroids. This figure shows all of the different locations where fibroids might develop. But in the middle of the uterus, a fibroid present there or a submucous myoma could significantly impact implantation and therefore should be evaluated in the infertile woman of advanced age. The evaluation could include a hysterosalpingogram, as shown here, and in the lower right you can see the appearance of a central filling defect within the uterus after the dye was injected, or with ultrasound, or what's known as hydrosonography or sonohysterography, one can demonstrate internal lesions in the uterine cavity as shown in the bottom figures. The bottom left, you can see what appears to be a fibroid or a polyp, but with injection of the sterile saline, that lesion becomes much more apparent, shown by the arrow. Ultimately, if a lesion is suspected, a hysteroscopy should be performed, and here are some examples of polyps or fibroids that are present inside the uterine cavity, and these could be readily removed using a hysteroscopic approach. Another acquired defect with age includes endometrial hyperplasia, which could be associated with obesity, anovulatory cycles, polycystic ovary syndrome, and usually is associated with abnormal bleeding and could be picked up by a biopsy or seen on ultrasound or sonohysterography. Endometriosis is a disease that often exists in older women, and it could lead to infertility or pelvic pain. Endometriosis is the presence of endometrial glands and stroma outside the uterine cavity. And here we see an example of different types of endometriosis, including red, white, and vesicular lesions. Adenomyosis is a form of endometriosis that is endometrium in the wall of the uterine muscle. Here shown with MRI using a T2 weighted image, the white dots represent adenomyosis. This inflammatory condition is associated with infertility, and this condition could be diagnosed using MRI or ultrasound. Systemic factors are also important when evaluating the woman of advanced maternal age. Acquired defects or diseases such as systemic lupus, hypothyroidism, and ovarian reserve issues should all be addressed in the evaluation of an older woman who is suffering from infertility. So in conclusion, the greatest impact on fertility during advanced maternal age is oocyte quality. The older patient has eggs of poorer quality, and this often needs to be addressed by hyperstimulation or using donor eggs. Acquired defects can still cause endometrial receptivity defects at any age, but should always be ruled out in patients of advanced maternal age who are ovulatory and appear to have sufficient egg number. You should always rule out endocrine, structural, systemic, genetic, and infectious causes that might be impediments to their fertility, and treat the underlying problems as you would in a younger woman. Thank you for your attention to this Pearlcast on infertility evaluation in the women with advanced maternal age. Thank you.